Hello, everyone, and welcome to today's live broadcast. Importance of measuring the inhibition of platelet thromboxanes by aspirin in cardiovascular disease management and prevention. Presented by Luis Lopez, MD, Medical Director, Corgenix Incorporated. I am Christina Mahalik of LabRoots, and I'll be your moderator for today's event. We are delighted to bring you this educational web seminar presented by LabRoots. LabRoots is the leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the green Q&A button located in the lower left of the presentation window and type your questions in the box that appears on the screen. We will answer as many questions as we have time for at the end of the presentation. Also, please notice that you will be viewing the presentation in the slide window. To enlarge the window, just click on the screen icon located on the lower right. If you have trouble seeing or hearing the presentation, please click on the support button at the top right of the presentation window or use the Q&A button to let us know that you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the button in the bottom left corner and follow the process for obtaining your credits. Please join me in welcoming Dr. Lopez. I will now turn the presentation over to him. Dr. Lopez?
Thank you, Christina, for your kind presentation. This morning, we are going to be talking about new developments that support the use of measuring platelet thromboxane and the inhibition by aspirin, and how we use this information in order to manage and prevent, cardiovascular disease. We are going to start our discussions by, presenting some information, some basic statistics related to cardiovascular disease. We are exposed by the news media about the impact of cardiovascular disease, not only in healthcare, but also in terms of economic and cost, impact in the population. This graph represents, the prevalence of cardiovascular disease. As you can see, the incidence of this, diseases are related to age. Most of the individuals are over 40 years old, both women and men. And as we can see that the population, continues to live longer, we would expect that cardiovascular disease will continue to be a problem in public health. So translating this into numbers, we see that only in the U.S., for example, there are about 100 million people with cardiovascular disease, and the estimated cost is in the range of about $300 billion. If we, look at the numbers, for the rest of the world, you can see that the number of, patients with cardiovascular disease will increase, and that will also increase the economic cost. Over the years, we have seen that the rate of mortality of individuals dying from cardiovascular disease had been increasing. This graph shows the mortality rate going up since the early 1900s, and reaching a point in around the 1960. That's when this the study of was conducted in Framingham and identified some of the most common cardiovascular risk factors. Programs, to control those risk factors were implemented at that time. However, we looked, to in the following years, the impact of these programs had been, not very effective. So today, most of the cardiologists and doctors in public health, they consider that the implementation of this program had provided only modest results. Why this, modest results? And we can probably discuss that there are multiple causes that will contribute, to these results. However, for this discussion, I can identify that there are two main problems that, should be pointed out. One is, and it can be shown in the graph on the left, that the prevalence of obesity in the adult population, 20 to 75 years of age, both in men and women, showed an upward, trend. So that is going to translate obesity into diabetes. And again, you can see the statistics and the projections, for the incidence of diabetes in the world in the next, 20 years is going to be, 65%. So these two factors will contribute to, the increase in the incidence of cardiovascular disease, or preventing, more effective, and better results in the programs that have been implemented. So in the last decade, many groups, cardiologists and researchers interested in atherosclerosis have been meeting, to review the impact of these classic, risk factors, meaning, the classic lipid profile. And the question that they have been asking is, have these risk profiles or risk biomarkers have been effective? I show here in this slide one of the early meetings that concluded that we definitely, have not seen a very good impact by implementing this, real biomarkers. If we attend any of the atherosclerosis or cardiovascular and even coagulation meetings, very often we see in the plenary lectures, the most important lecture for those conferences, that cardiologists use the topic of cardiovascular disease in presentations. Quite often we see titles like "Why We Missed the Mark on Preventing Cardiovascular Disease." What I presented here is one of those lectures that was presented at ISTH in 2015, held in Toronto. After going through all the economic impact of cardiovascular disease, and the medical and economic impact in the population, the conclusion is, we are definitely not preventing cardiovascular disease, and one of the reasons is because we're failing to develop and use new effective early risk biomarkers. So the answer in very simple terms is yes, we do need new and better cardiovascular risk biomarkers. The other concept that I like to mention in this presentation is, the very simple view of what is cardiovascular disease, and more specifically, the atherosclerotic cardiovascular disease. This, now is known that it's a chronic and progressive disease. It can be, and usually it's it is asymptomatic, and even may start early in life. The problem is that atherosclerosis has multiple factors. But to simplify this concept, what I like to do is divide this into two components. One is, the blue box that you can see, which is systemic. So it's a component that is present in blood. And that component will result in platelet activation and platelet aggregation. And when we talk about platelet activation and aggregation, we talk about thromboxanes. Those are the molecules that will activate platelets. So, the platelet activation will result in, increased arterial thrombosis. At the same time, patients with atherosclerotic cardiovascular disease will have a second component that is localized in the tissue, and that is related to inflammation, and we call oxidative inflammation, that is associated with abnormalities in lipids, activation of macrophages, the development of the classic foam cells, and even an immunological response by activating lymphocytes. And all this will result in the formation of the classic plaque in the arterial wall. So these two components, they seem to be separate, and they seem to be unrelated. However, now we are discovering more of mechanisms that will connect, and the consensus is that there is a very active cross-communication, cross-talk between the systemic and the focal tissue. Today, we are going to be talking mostly about the systemic component, which is related to platelet activation, and how aspirin, this the ASA symbol that you see there, it represents, the aspirin use, and how aspirin affects, this first component, and in any case, how that effect is going to affect the crosstalk of communication with the other focal and tissue component. And right there in the middle of this cross-communication, I'm going to introduce one term that is called oxidative stress, oxidation, and inflammation. So it's an inflammatory response that is triggered by different oxidation mechanisms that is called, in general terms, oxidative stress. So now this is becoming, more and more important as a factor in atherosclerotic cardiovascular disease, and we are going to refer to this term in several occasions during this presentation. The other component that we need to discuss is, related to platelets. Platelets are, the main source of these thromboxanes. But platelets, are very small cells in the blood, but they have a very active, a system of enzymes and metabolic pathways that are connected to receptors in the surface as represented, in this diagram. There are very many, there are different and many receptors that, have different functions. Today, we are going to focus our discussion mainly on one, of this a receptor and metabolic pathway, and that is the pathway that starts with the arachidonic acid right in the circle, and that, arachidonic acids by enzymes converted into what we call thromboxane A2. Thromboxane A2 is the metabolically active thromboxane that will activate platelets by binding to the receptor, the thromboxane receptor on platelets. So this a pathway is inhibited by aspirin. So aspirin, will decrease the production of thromboxane A2 and reduce, the platelet aggregation. That is going to be basically the focus of today's discussion. So, as I mentioned, thromboxane A2 is the physiologically bioactive molecule. The problem is that this molecule is very difficult to measure because the shelf life is very, very short. It exists in circulation in a very, very short period of time. But in that short period of time, thromboxane A2 can promote platelet activation, aggregation, blood clotting, even has a role in hypertension. So what we need to do is we try to measure indirectly the action of thromboxane A2, and for that we go to a metabolite of thromboxane A2 that is called 11-dehydrothromboxane B2. And that is going to be the molecule that we are going to discuss today. And this thromboxane B2 is a stable metabolite that will reflect the production of thromboxane A2. So the question here is, can we really use this 11-dehydrothromboxane B2 metabolite as a biomarker for cardiovascular risk? And all the discussions is going to try to address this question. Now, because as I shown, aspirin inhibits that thromboxane A2 pathway. Aspirin has been used for many years as a way to prevent cardiovascular, disease. And the action of aspirin is on an enzyme that is called COX-1, or cyclooxygenase 1. Aspirin acetylates, and inhibits, that enzyme. So it will activate the enzyme for the life of the platelets, and that will produce a decrease or inhibition of thromboxane A2 and all the other downstream metabolites of thromboxane A2. Now, aspirin is being very, very effective in the sense that it actually blocks most of the COX-1 activity. So because of that, over the years, aspirin has been a very cost-effective prevention for atherothrombotic cardiovascular events. Now, here is, a summary in the red box, a summary of the publications that have over the years shown that aspirin is a very good, drug to prevent cardiovascular disease. Well, all this sounds good, but we're going to see that there are some problems with the inhibition of thromboxane B2 with aspirin. But before we go into that, I'd like to summarize what I just mentioned. The pathway of thromboxane A2 and thromboxane B2 production. In the center, on the top, in the middle, we have the membrane phospholipids that will be metabolized or converted by the action of different phospholipases into arachidonic acid. Arachidonic acid will be converted into several prostaglandins and then thromboxane A2 by the action of cyclooxygenases. Cyclooxygenases, or COX enzymes, can be COX-1 or COX-2. COX-1 is only present basically on platelets, so the COX-1 is, the action of COX-1 is basically related to platelets. And the COX-2 is present in some other cells, like inflammatory cells, and they can also, COX-1, cyclooxygenase 1 and 2, will produce thromboxane A2. Because thromboxane A2 produced by either of these two enzymes will be then metabolized into more stable, products, and that's, thromboxane B2, and further in the liver, and further metabolized and excreted in the urine as the 11-dehydrothromboxane B2. The test that we are going to talk today is the an ELISA test that measures the urinary levels of 11-dehydrothromboxane B2. So levels of urinary thromboxane B2 will be the reflection of the thromboxane A2 produced either by COX-1 or by COX-2. When we put a patient on aspirin, as I mentioned before, will only inhibit the COX-1, and that is present on platelets. So platelets would not be able to produce the thromboxane A2, and as a result, will have decreased levels of B2 and urinary thromboxane B2. However, we have the COX-2 pathway on the left side of this diagram, and that COX-2 is not affected by aspirin. So if we measure high levels of thromboxane A2, most likely those high levels, usually referred as residual platelet, thromboxane A2, are going to come from the COX-2 pathway that is not affected by aspirin. And we are going to use this concept in order to, measure thromboxane and see, how we can use the inhibition of of thromboxane in cardiovascular disease management. As I indicated, aspirin has been used for many years, and it has been very effective, in general terms. However, it's been recognized for quite some time that not all the patients benefit from aspirin. Sometimes we can see reports that up to even 60% of patients, especially populations with active diseases, diabetes or cardiovascular, they fail to respond to aspirin. And, those individuals have been, thus lack of response have been, referred to in the past as aspirin resistance. Now we believe that probably the term is not really a good term, and more appropriately should be referred to as poor or incomplete aspirin response. In Europe, some people prefer to call this condition a high platelet reactivity while taking aspirin. The importance of determining this aspirin resistance, whether you respond good or you respond bad to aspirin, is because there has been publications that associated this lack of response or resistance to aspirin with cardiovascular risk. These patients have been shown to have up to about 4 times increase the risk for development of cardiovascular complications compared to those patients that did respond well, to aspirin. So the term of aspirin resistance has been around. We're going to use it in this presentation because it's quite common, but with the understanding that we prefer to use, poor response to aspirin. In reality, aspirin resistance is not a clinical entity. It's not like a disease, or has not been really defined or standardized, and unfortunately there is no treatment for that. So, however, this is an observation that probably we need to look for in the laboratory in order to identify those patients that have poor response to aspirin and see how we can then modify that increased risk for cardiovascular complications. Well, what are the mechanisms of aspirin poor response? If we review the literature over the few years, probably number one is patient compliance. Patients that say that they're taking aspirin, but they are not. And then, there have been publications, that suggest that in some cases we have thromboxane A2 production by other pathways. One of those pathways is the COX-2 that we just reviewed in the previous, slide. We have also, seen patients with, problems because of the type of aspirin, the interaction with some other drugs, gastrointestinal absorption, and finally, it's been proposed that possible genetic variations of the COX-1 enzymes. This actually has been studied with certain details, and it has been shown that there is no, really an important impact of COX-1 genetic polymorphism with the COX-1. However, in the last few years, more and more publications come now that show that oxidative stress and inflammation, the term that I mentioned before, is now becoming an emerging factor that explains why these patients don't respond very well, or don't respond to aspirin, and so we can identify those individuals as aspirin resistant. And it's important then to use this information as a way to modify this condition. Can we, the clinical relevance of identifying aspirin resistance will be, as a factor that can be modified in order to decrease cardiovascular risk. And that's, probably the main importance from the clinical point of view why we need to identify these patients. Few words about the test kit that we use to measure this. This is the 11-dehydrothromboxane B2 test kit. is an ELISA for the urinary levels of this metabolite. It has been, approved or cleared by the U.S. FDA, and it's been in the market since, 2007. And basically is, used in order to provide an aid in the qualitative detection of the aspirin effect. So we use this test to measure thromboxane and then assess whether aspirin is, working in these individuals. We use the 11-dehydro molecule, okay, as the analyte to measure, in this competitive ELISA, because the 11-dehydrothromboxane B2, as I indicated, is a stable metabolite with a long circulating half-life, and ex vivo is very stable. Well, at least 2 weeks, room temperature, even longer at 4 degrees, and indefinitely frozen. Also, we use this metabolite because we measure this metabolite as an indicator of the thromboxane A2 generation. And thromboxane A2 is the target for aspirin therapy. Now, by using urine in this system as a matrix for the thromboxane B2, we minimize pre-analytical variables like venipuncture that can be a problem with certain blood-based tests that try to measure the same metabolite. So when we obtain the blood, for example, with the urine, okay, the urine is not subject to ex vivo activation. This is a very common problem that we can encounter with platelet aggregation assays. So we use then random urine. We can, just any, a urine specimen and measure the thromboxane there. However, we normalize the results of, picograms of 11-dehydrothromboxane B2 with urine creatinine. So at the end, the results are normalized, to picograms of thromboxane B2 over milligrams of creatinine. And this way, we have a consistent, measurement of thromboxane that is useful in the laboratory to compare patients, to follow patients, in different, activities. And one comment is why urine? We are using urine to measure this thromboxane, and why not using serum or plasma? We have tried to measure thromboxane in serum, and you can probably measure and use the results for one experiment. But if you want to be consistent, lot-to-lot consistency, lot-to-lot results, over time, urine provides the best matrix because in serum there are so many proteins that can interfere with the protein, and because thromboxane is a small molecule, you can get inconsistent and interference, with the results. While urine provides a matrix that has no, excess proteins on other molecules, and therefore it provides, very, very consistent, clinically useful, levels over time. So this is the reason, basically, urinary thromboxane is measured over, all the assays. One of the questions then is, okay, if we can measure thromboxane B2, what are the levels that we can use in order to determine whether the patient is good responder to aspirin or a bad responder to aspirin? What is the level, to determine, aspirin resistance or not? This is one of the early studies that we performed, and a population of healthy individuals were measured urinary thromboxane B2 levels without or before taking aspirin. As you can see in this graph, the distribution of values in the black bars, it has a very wide range that goes from, less than probably 900 all the way over 6,300. So the distribution is very, wide. When you put this patient on aspirin, okay, all these values, the thromboxane dynamics are, as you can see here, pushed to the left. So the majority of the patients are going to be, in the range of less than 1,500 to the left of the vertical broken line. So we use this line, 1,500, due to this type of response as the cutoff to call good response from bad response to aspirin. So you can see in some patients taking aspirin on the right side of the vertical line in a very small, numbers. So those will be, considered individuals that are not responding well to aspirin. So we have tested many populations, healthy as well as diseased populations, using this type of analysis. And for example, here you can see in the graph that patients with diabetes, the number of patients that have poor response to aspirin increased from 7 to 9% in healthy subjects to about 14%. And patients, populations with acute coronary syndromes went up to 30 to even 50%. So this cutoff was a good, number to useful number to classify aspirin resistant from non-aspirin resistant. This graph in the next slide, this slide, shows this type of results. The blue columns on the left represents the control population with the mean value of thromboxane. These patients blue are not taking aspirin. This is the baseline. You can see that the mean level is about 2,500, and the bars are the range. The range, going all the way up to 10,000. When you plot, diabetics next to that, next to the controls, you see that the mean value increases, goes, to about close to 4,000, and the range also, is expanded to about 20,000. And when you have acute coronary syndrome patients that have, more active disease, cardiovascular disease, you can see that the mean values go up to 7,000, but the range go even higher to levels, over 100,000. You can see then that there is a tremendous overlap, in these values. So we analyzed these values of thromboxane 11-dehydro in patients not taking aspirin. And we could not, even with those high values, we could not predict, outcomes, cardiovascular adverse outcomes in this population. So this cannot diminish, the value of using, 11-dehydrothromboxane B2 levels in the clinical setting, because, those values don't have predictive, clinical utility. However, if we go to the right, graph, the red column, these are the percentage of patients that are good responders to aspirin. So these patients have already taken aspirin, and you can see that the control have, a 7% of patients poor response to aspirin. Diabetes double, as we have seen before, and it went up to about 30% with acute coronary syndrome patients. However, you use this data of these numbers after taking aspirin, 11-dehydrothromboxane after taking aspirin, and then do the projections, the statistical analysis to predict, cardiovascular adverse outcomes, and you could actually predict. So these values have, good predictive value. And so we are, now saying that this is the aspirin response or the lack of aspirin response after taking aspirin. Those values have clinical utility in predicting, outcomes. So it becomes important for the laboratory, to, implement a test kit to measure, to test for aspirin resistance. So we are proposing that, one of those tests is the urine test. So the urine test that we mentioned before, and that test will measure the production of 1100 thromboxane B2, which is the metabolite that reflects, thromboxane B2. In a patient that is taking aspirin, okay, that 11-dehydrothromboxane B2 that we measure with the test is basically a reflection of thromboxane A2, okay, and that is an indication of, a direct effect of inhibition of COX-1 by aspirin. There are other tests that we can use, and it's been probably some laboratories use that are based on blood. So blood tests to measure aspirin resistance rely on platelet stimulation and, the platelet response through diverse mechanisms. Here is that, we tend to stimulate those patients using many of those receptors that I show at, in the one of the early slides. You can see that there are different tests in the market listed, here, Platelet Works, the TEG, Verify Now, PF100, and all that. All those tests depend on, extraction of platelets and stimulation with agonists, and then measure, that platelet response and aggregation. The problem is that these tests have been shown over the years that they don't correlate very well with each other, and they don't even correlate very well, with the thromboxane B2 production. So, and probably, part of the explanation is that that these tests, rely on so many other, receptors and pathways that stimulate the platelet aggregation that, probably will, modify, or affect, the correlation status. So we are proposing that probably thromboxane 11-dehydro is probably the most direct and clean way, and and that's the data that we are going to be presented to confirm that. More recently, we have run into different results from different groups. Some are collaborators. They try to address the question of what is now then the clinical utility, what is the clinical correlation of urinary thromboxane with cardiovascular risk factors. One recent set of publications that was presented in the ISTH meeting recently in Berlin that measure urinary thromboxane B2 in a population of type 2 diabetes that were all these patients taking aspirin, and also measure inflammatory markers like CRP, hypercoagulability, with the TEG, and high platelet reactivity by platelet aggregation, different platelet aggregation assays. Then, these patients were separated by, the degree of inflammation, CRP, in high inflammation and low inflammation, as you can see in the left, graph, okay? In the middle graph, you're going to see high hypercoagulability and low hypercoagulability. And in the graph on the right side, platelet aggregation, high platelet aggregation and low platelet aggregation. So you can see that 11-dehydrothromboxane B level correlate with, low levels of inflammation and low levels of thromboxane. High levels of inflammation, high levels of thromboxane. And the same, is true for the TEG hypercoagulability and platelet aggregation. So this indicates that it follows 11-dehydro levels follow the levels of inflammation, hypercoagulability, and platelet aggregation, or risk factor for cardiovascular disease. One other question is how the thromboxane V2 compares with platelet aggregation assay. I was able to only find one independent paper published in the literature that measured the urinary thromboxane V2 side by side in a patient or a group with a stroke. This and also measured platelet aggregation by the Verify Now, which is one of the platelet aggregation assays. This publication was published in Thailand, and the reference is there for you to review if you are interested in further looking at this. What happened is that in this publication, that thromboxane detected 40% of this stroke population as aspirin resistant, and at Verify Now detected only 6% as aspirin resistant, as you can see in the bottom table. The way to then interpret these results is who's right, 40% or 6%. The adverse outcomes were studied in this population, and as you can see, the 11-dehydrothromboxane correlated 40% correlated with 18% of mortality in this patient population, and the 6% correlated with only 2% of mortality rate. So one interpretation is that Verify Now means about 14% to 16% of mortality rate in this patient population by not detecting those patients with aspirin resistance. So we have seen this type of results more in the 40% in many other publications, indicating that probably urinary thromboxane V2 has a better correlation with adverse outcomes and mortality. This graph, this slide represents a summary of a meta-analysis published a few years ago. Several 20 or 25 different publications, thousands of patients, and they were classified as aspirin resistant by different methods, and then correlate that aspirin resistance with cardiovascular outcomes to determine the risk. What you can see is that in the middle, the vertical line to the right of the vertical line means increased cardiovascular risk. To the left of the vertical line, decreased vascular risk. Most of these publications, except probably one, have indicated or have correlated aspirin resistance with cardiovascular risk. This is this information that supports what we mentioned early in the presentation, that poor aspirin response correlates with increased cardiovascular risk. Two studies that were done some years ago, the HOPE study in 2002 and the Charisma in 2008, were the first studies that showed 11-dehydrothromboxane V2 as the marker to assess cardiovascular complications. This study was done in about 500 patients, all with cardiovascular disease and all taking aspirin. As you can see in the graph, the higher the level of thromboxane, urinary thromboxane V2, follows the increased risk for complications, and that also included death. So the question here is, what makes the patients with poor aspirin response or aspirin resistance different? What makes them, more prone to complications, and why they have increased, mortality? Several years ago, with some collaborators, we studied patients, a large population of patients with coronary artery bypass that were taking aspirin. We measure serum CRP in this patient population as a marker for inflammation, and you can see those results on the left graph, and on the right graph, a urinary 8-iso-PGF2 alpha, prostaglandin F2 alpha. This marker, 8-iso-PGF2 alpha, is a marker for in vivo oxidation, known for as correlated, for this increase, oxidative background. You can see here that serum CRP is higher in patients that are non-responders to aspirin compared to patients who are responding to aspirin. And here also for 8-iso is the same distribution, higher in vivo oxidation in patients not responding to aspirin compared to those responding to aspirin. So it is clear in this study that there was an oxidative inflammatory background in those patients that have poor aspirin response or were aspirin resistant. So to test further this hypothesis, in collaboration with our friends in Baylor University, the cardiovascular group there, Dr. Peter McCullough, we study a large patient population that were diagnosed or having cardiovascular disease by angiography, and you can see the criteria in the green box. Of all these patients, about 449 were patients that were taking aspirin and have complete information, samples, and all that to be able to be included in the study. Then we measure in these patients by ELISA the urinary levels of 11-dehydrothromboxane B2, and that was a marker for aspirin response. At the same time, in the same patients, we measure ELISA urinary 8-iso-PG2 alpha, which is, as I mentioned, a marker for oxidation. And we use the 11-dehydrothromboxane B2 levels to classify the patients in lower tertile group, in the middle tertile group, and an upper tertile group. You can see, here that patients in the lower tertile, so after taking aspirin, they have low levels of thromboxane, so they probably can be classified as good responders. The mortality rate in this population was only 2.7. This is a 4-year mortality rate. In the middle tertile, you can see down at the bottom, at the middle bottom, is 18%. And then in the upper tertile, with, in spite of taking aspirin, they have high level of thromboxane, the mortality rate increased to 25%. So definitely there was an association, it seemed to be an association between, 11-hydro, levels after taking aspirin and mortality rates. In this graph, we have the summary of the different clinical and demographic variables that we study in this population. This is a busy graph, but only to point out at the bottom of this table, in the green, part of the table line, that 8-iso-PG2 alpha was one of the very important and statistical significant, association with 11-dehydrothromboxane B2 tertiles. So this suggested that there was an association between higher levels of, thromboxane B2 with also higher levels of 8-iso-PG2 alpha, as we have seen before. When we do the statistical analysis, the adjusted and unadjusted, linear regression, I just want to point out that in the green, section of the table, you can see that 11-dehydrothromboxane, 8-iso-PG2-alpha continues to be a very strong association, by independent, strong association with the 11-dehydrothromboxane B2 levels. So it clearly showed that these two variables, thromboxane and isoproteins, were somewhat, interacting or present with clinical relevance. This slide shows the visual representations of two tables that I just mentioned. So basically, the graph on the left side is on the horizontal axis, the tertiles of 11-dehydrothromboxane B2, and in the vertical 8-iso-PG2-alpha. As you can see, that increasing levels of thromboxane with the tertiles also follow increasing levels of thromboxane B2. And the correlation, a strong correlation between these two variables is shown in the graph on the left side. So if we review the statistical, interpretation, analysis of, all this data, the conclusion is that patients that do not respond to aspirin, so in spite of aspirin, they have increasing levels of thromboxane, these patients at the same time are going to have an independent increasing on parallel increasing levels of 8-iso-PG2-alpha. I'm going to put then these results in a graphic, representation. So I modify the slide that I presented, early for the, the metabolic pathway of production of thromboxane. So what I did here is, try to separate the platelet pathway or COX-1 pathway that you can see on the right side of this slide. Okay, the platelets will produce arachidonic acid, and the COX-1 will be inhibited by aspirin, so there will be no production of thromboxane A2. So when you put a patient on aspirin, any individual, as we said, most of them respond very, very well to aspirin. So basically what you do is you eliminate that pathway from the equation, so you don't see that. So whatever is left in that individual that is taking aspirin is going to come from the inflammatory pathway. And in this case, the inflammatory pathway is going to start with basically two cells, macrophages and endothelial cells. Probably endothelial cells have a more important role here, but they are significant. These inflammatory cells will also produce the arachidonic acid, right here in the middle. And arachidonic acid can be then converted or metabolized by going to the left by the inflammatory COX-2 pathway into thromboxane A2. Or that arachidonic acid in the middle is going to be further, metabolized or converted by the action of reactive oxygen species. The ROS here represents the oxidative, attack, and this is a non-enzymatic, oxidative pathway, and produce, 8-iso-PG2-alpha. So patients that are on aspirin that don't respond very well to aspirin because they have high levels of this thromboxane that we measured, they also going to have high levels of 11-dehydrothromboxane PGF2-alpha. Now, there are now several in vitro publications that have clearly shown that 8-iso-PGF2-alpha can stimulate directly the thromboxane receptor of platelets. So now these patients have stimulation of platelets by two elements, the thromboxane A2 and the 8-iso-PG2-alpha. How this then influence mortality? This study, this information has been recently published. If you look at, first the thromboxane tertiles or thromboxane levels happen after taking aspirin, you see in the graph on the left that lower tertile had a very low mortality rate, as we mentioned before. But when you go to the middle tertile, the mortality rate increases significantly and increasing further when you go to the upper tertile. On the right of this, you have the survival, the survival curves, which is the reflection of the mortality rates, and you can see how the mortality rates survival rate will decrease, over time. If we do the similar analysis but incorporate the 8-iso PGF2 alpha, we can see in the lower half of this graph on the left side, the first two columns is the low thromboxane B2 with low 8-iso and high 8-iso. The mortality rate is relatively low compared to the right side of this, which represents high thromboxane and low 8-iso and high 8-iso PG2 alpha. So the combination of these two, thromboxane and 8-iso PG2 alpha, will increase the mortality rates in this population. And if you do the same analysis for survival estimates over time, you are going to see that there is definitely an interaction between these two by decreasing the survival rates in this population. So do we can use the 1500 cutoff that we determined before in order to call the patient with aspirin resistance or aspirin poor response, and how this for prediction of mortality, and can this number will be of clinical value to further studies to minimize the mortality prevention. In this graph, what we have done is basically ROC analysis for mortality, and we determined that in this analysis the optimal point in this curve for mortality rate corresponded to the 1500, I think 97. So that corresponded to the 1500 level that we have determined before. So this indicates that 1500 is a cutoff point that will have clinical value in order to assess mortality rates and guides treatment for prevention of these cardiovascular diseases. Before I go to final and concluding remarks for this presentation, I just want to mention briefly that in the most recent recommendations for assessing cardiovascular risk, one of the focal points that the recommendations have published is that we have to target cardiovascular risk, not just cholesterol. And to modify the cardiovascular risk, statins are probably right now the only medications that seem to be doing the job. And we better kind of focus on the bad cholesterol, on the LDL cholesterol. But more importantly, especially for this discussion, is that the new recommendations now are including other factors. And one of the factors that this recommendation included is to measure CRP, and CRP as an indicator for inflammation. So inflammation is becoming an important factor in cardiovascular disease. And most recently, this is probably was presented about 2 or 3 months ago in a cardiovascular meeting in Europe, that that for the first time, there is a drug that has been used in order to attack the inflammation in cardiovascular disease to prevent, the heart attacks. Okay, and this is a new and very different approach than just lowering cholesterol. So this is, indicating that there are some other factors that have to do with, inflammation in cardiovascular disease, and that factor is, the interleukin-1 beta, and that has been, indicated that inflammation, some other factors besides, just pure cholesterol, are very important in cardiovascular management, and hopefully, in improving the diagnostic, utility for early prevention of cardiovascular disease. So I'm mentioning this because this information is tied to what we have just mentioned, that there is oxidation, there is inflammation, there are other factors that contribute to development of cardiovascular disease, and they also contribute to morbidity and mortality, and we need to pay attention to those factors in the near future. So the clinical interpretation for dihydrothromboxane B2 can be, summarized in this way. Only valuable for patients taking aspirin. I think that's the best utility of this information, only in taking aspirin. If you, after taking aspirin, you have levels that of thromboxane B2 that are below 1500, okay, then you have a good, minimal risk, and no further action is probably necessary. And the reason for that is because you don't want to keep pushing aspirin in these individuals and increase the risk for bleeding and some other complications. But if you are a full responder to aspirin, so you will have levels over 1500, then you are going to have an increase for cardiovascular risk. You better check, for some other reasons that your thromboxane levels are not very low, like compliance, absorption of aspirin, drug interference, and all that. But if you rule out those causes, then you need to then have to modify, the patient management by modifying the dose of aspirin or adding, additional medications and probably some other COX-2 inhibitors or other antiplatelets or other anti-inflammatory, medication to, minimize the levels of thromboxane as real marker for vascular disease. So in summary, if we put all the information together, we can say the following. The 11-dihydrothromboxane measurements after you take aspirin are important for the following reasons. One, that you can identify those patients with poor response to aspirin, or you can identify those patients with aspirin resistance. By identifying those patients that are poor responders to aspirin, because you need to pay attention to the increased cardiovascular risk, and that reflects also a increased mortality rate and decreased survivals in the following 4 to 5 years, as we have definitely shown. And finally, those poor responders will require additional or alternative antiplatelet or anti-atherogenic or antioxidative inflammation intervention. And this is basically the final message, and I want to thank you for your attention, and I'm now remain to answer any questions or comments that you may have. Thank you very much.
Thank you, Dr. Lopez, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the green Q&A button at the lower left of the presentation window and type your question into the box that appears on your screen and click the send button. We'll answer as many questions as we have time for. So without further ado, let's get started with our first question of the day. And that question asks, can you test for urinary 11-dehydrothromboxane B2 levels in patients not taking aspirin?
I haven't heard any questions. Okay. There is one question here that I just received. Can you test for urinary 11-dehydrothromboxane B2 levels in patients not taking aspirin? Yes, the answer is that you can measure those levels. However, the clinical utility, the clinical value of those levels are limited. And as I've shown, there is a wide range of urinary, thromboxane B2 levels in normal population and diabetes and cardiovascular disease patients with a significant overlap. So the clinical value of that information is that that patient may probably have a background with oxidative stress and increased cardiovascular risk. However, in order to be absolutely sure and increase the accuracy of that information, it's better to put those patients on aspirin and then measure the thromboxane levels after taking aspirin, because those thromboxane levels have clinical value and increased correlation with complications, increased mortality, and all that. So that's why, you can measure, the levels of urinary thromboxane B2 in patients not taking aspirin, but the clinical value, the clinical utility will be limited, and it has to be interpreted with caution. That's my suggestion.
Well, thank you for that answer. The next question of the day asks, why is urine used as sample matrix instead of serum or plasma for measuring 11-dehydrothromboxane B2?
Yes, the simple answer is that, thromboxane B2 is a very small molecule, and is subject to interference with many other substances that can be present in the matrix. So when you have serum, you can probably measure the small molecule, the thromboxane B2 molecule, but the presence of other larger and high concentration proteins may interfere, with the test. So we tried that to develop, a serum-based test, but we could not get the assay to work in a consistent way for clinical use in the laboratory. Where you have to have, consistency, lab to lab, over time, and so on. And the best results that we were able to obtain and with all the clinical correlation is with the urine matrix, because the kidney actually removes, all these excess proteins and cleans, the matrix. So then when you measure, this small molecule, it will have a lot less interference and therefore more consistent results that will increase the clinical value of that measurement. Thank you.
Well, once again, thank you for your answer. We appreciate it. It looks like we're running out of time today. So the last question of the day we'll ask, is 24-hour urine collection more accurate than random urine sample to measure 11-dehydrothromboxane B2?
Yes, you can use 24-hour urine and, to measure, thromboxane B2 levels. However, we can overcome that issue and by using creatinine, urinary creatinine levels, and the ratio of thromboxane B2 levels over creatinine in any spot urine or any randomly obtained urine. So then we don't have to, by using urine creatinine, we don't have to collect 24-hour urine, and the results are very consistent and they are quite valid.
I would like to once again thank Dr. Lopez for his presentation today. I would also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to let everyone know that today's webcast will be available for on-demand viewing through February 2018. You will receive an email from LabRoots letting you know that the webcast will be available for replay. Please share that announcement with your colleagues who may have missed today's live events. For now, this is Christina with LabRoots. Thank you for joining us, and we hope to see you here again soon. Goodbye.